everyone for coming tonight on this cold evening. So I guess Danielle and I share a pretty similar history in some ways. Some ways it's different. I'm a cardiologist by training. Danielle took the road of like family medicine, which I think in many ways you get to chat with your patients a lot more than you do in cardiology. But I think partly the themes you're going to see are going to be pretty similar. And I guess one of the things, just so that I'm not completely saying exactly the same thing that Danielle said, is a lot of, at least in my history, it all happened through happenstance and circumstances. That you weren't actually planning for things to happen, but they kind of did happen. And I think probably one of the key messages I'll say for people, because I guess this is partly how did we get here and what are the things you can take away, is opportunities sometimes just happen and you have to sort of seize on those opportunities. And I think the key is your ability, the training that you're going to get and things you're going to be doing now are going to make you able to seize on those opportunities. So it's not just that the opportunities present themselves, but do you have the skill set, the desire, the will to want to be able to seize on them and make them happen. So in fact, it was interesting because my whole journey in health policy actually started with Danielle. So I was a resident in internal medicine. I wanted to be a doctor who saw patients, and that's kind of all I thought I was going to do. And I thought I'd be, probably a researcher of some kind because I really was interested in that. And I met Danielle at PARO, which is, if any of you know, the Professional Association of Interns and Residents of Ontario, where Danielle was president. And some of the things that really were interesting is this was at the time when they were creating something called the New Health Professionals Network, which was this whole thing around Medicare and Medicaid and or Medicare and sustaining it, making sure we didn't have a two-tier system. And so Danielle had sort of guiled me into helping her with some of the work that they had done. She was a real champion in this. And I kind of caught the policy bug at that point in time. And I was like, wow, this is really neat. And being able to impact change. And the thing that I remember about Danielle at the time was how, and it struck with me is, and I think it's another key message for you guys, is that oftentimes when you're young, you don't actually think you can make change, but in fact, you really can. And I remember watching Danielle up on the news and in press conferences and stuff, and being amazed that somebody who was so young was actually able to make a difference. Because I think people are always listening for fresh voices, and so again, this was the thing that actually really struck me. And so you realize that you could make change, and so I really caught the policy bug. And then partly through the relationships that I made at PARO, I actually continued on my cardiology training, internal medicine and cardiology training in Toronto, done some research on the side. And then, you meet people, and then, again, you say, well, maybe we'll grab breakfast here and there, we'll grab drinks, and then, you have a few conversations here and there with different people that you meet along the way, and suddenly an email comes and it says, hey, would you be interested, this was in 2007 after the provincial election, in coming to talk to us about possibly a job. And I said, this is weird. Okay, so I actually met with who was the senior policy advisor to the premier at the time. And I guess we had chatted, again, this is just sort of happenstance. And then finally, I'd gone through a bunch of different chats. They weren't really called interviews. They were just like, let's meet for coffee. Let's go to their office for tea. And then eventually it was like, hey, would you like this job? And so I said, great, can I do it part-time as a resident? And they kind of said, no, it's kind of a full-time gig. So in 2008, it was actually a choice where do I continue on my cardiology residency, start a research career and kind of maybe get a PhD or do something like that, or do I leave medicine completely, put on a suit and actually work as the Premier's healthcare policy advisor. It was a weird decision actually because the truth is you kind of think your life is going one way and then suddenly it's going some way completely different. And I kind of thought, would I regret this 30 years from now if I decided not to do it? And I kind of said, sure, like why not? Well, it was after a conversation with my wife over a bottle of wine, and we said okay. I spent 2008 to 2010 working for Premier McGinty at the time, doing his health policy. Then I came back to residency, which was a total shock. because you end up at the time being like, you know, a guy who can get in the room with anyone in the province, to suddenly being a guy who's like back to being a resident again. And if any of you know what that's like, it's pretty close to being like the lowest form of life on the planet. So that was fascinating. And then, you know, but I think my time in government, just like Danielle's time in government and our time, has really like kind of made me think about the way that we utilize healthcare resources. And the potential, not in a negative way, but actually the potential opportunity that exists, you know, in a system like ours, like a publicly funded healthcare system, where it's a single payer, that we can do some really cool things that becomes really difficult to do other places. And that became even more stark for me, because in 2011, I left to go to Boston for 2 years to do some training down in the States, and our system made so much more sense. Because, you know, there the challenge is patients that are across the street from one another may not be able to interact with the same institutions, may not be able to go to the same doctors, may not be able to do a lot of things because of the competition around insurance. And so, again, I became interested in how can we actually spur innovation in a place like this, where in fact, although everyone talks about the US being a hotbed of innovation, the truth is there's so many things that prevent health system design, health system redesign, and innovation in, you know, in the U.S. because of the competitive nature of healthcare insurance. So, you know, then again, in happenstance, as I was looking for a job back in Canada, this sort of opportunity came up, and I thought, hey, it kind of blends a lot of the things that I had done. So, you know, part of what we're thinking about at Leave, and part of my job is actually to figure out what this actually was going to mean, was trying to go where other people aren't. So that's another sort of key take-home point is if you're thinking about doing something unique, try to tackle big problems like Danielle said, but try to tackle things that people aren't necessarily doing right now. So we kind of decided that we were going to do two big things, two big areas of focus, which are the focus for the Institute going forward. The first is in the area of quality improvement. Now everybody's doing quality improvement. But the interesting thing is a lot of the quality improvement you see right now is done in the hospital sector. It's done, you know, in the big teaching hospitals, the big community hospitals. But in fact, not as much is being done in the area of ambulatory care. Partly because it's really hard, partly because the resources don't always exist there. So we said, you know what, ambulatory care, the transitions of care between family doctor, specialist, between, you know, emergency room and home, between hospital and home, even between some of the other institutions that exist, that's often where things fall down. And the literature is pretty clear on that's an area where we can do a lot better, and not just us, but everywhere in the world. So we're really making a huge focus of trying to try to redesign care to improve ambulatory quality of care, getting patients access to specialists quickly, ensuring that patients don't go to the emergency room but go somewhere else, particularly those that suffer from a chronic disease. So that's one big area of focus. The other big area of focus that we're interested in is value. And I'm just going to say it because this is a pretty, we try not to say value for money, but we actually do mean value for money. And why is that important? It's important because not just in this system, but every system around the world needs to think rations in some way or another. In the U.S., they ration on the basis of insurance and their ability to pay. In other systems, they ration on the basis of need. You know, everybody does it to some extent because healthcare resources are not infinite. But more importantly than simply the idea of money is the idea that we want to ensure that everybody gets high quality, efficient care. Because oftentimes we now know that getting care that is unnecessary can also be harmful, can also cause anxiety, can also have unintended consequences. And it's an area that everybody talks about, this idea of appropriate use of medical care. But again, is an area that if you look at the literature is a new, evolving area. There's not a ton of any definitive answers on this. So we said, you know what, this is an area that I think we can go into. And we can talk about some of the work that we're doing. But our idea was two foci, and again, that really dive deep into what this really means, not just for women's college, but also the province and the rest of the country, and hopefully internationally. Part of the philosophy that we have at Women's and at the Institute is really the idea of using this place as an innovation laboratory. So what I mean by that is we're going to try different things here. They're not necessarily, although we've got the virtual care, everyone thinks I'm going to be walking around with Google Glass, and I'm not. The idea is, how do we take the technology that we have, how do we take the interesting new training that people have, how do we take all this innovation and actually be able to use it to improve the outcomes of patients? How do we evaluate what we're doing? So our idea is to design, implement, and evaluate new ideas in this learning laboratory that we have with one of the most valuable resources in the province, which is patients. And then if it works, we scale it, and if it doesn't work, we don't do it anymore. And that was kind of to Danielle's point. So that's conceptually what we're thinking about here. Going to be honest, this is a long road, and we're just starting. I'm 6 months in, so I'm not that much farther along than you guys. But I think there's a tremendous opportunity for us to do things differently, and we want to prove that in a single payer system like in Canada, we can actually be very innovative, do very innovative things, and actually show value for the system and for the payer and the taxpayer of Ontario. So I'm going to stop there, and I'm going to let either Danielle respond, or I think what might be really helpful is that we can just take your questions.